Question 1. Which of the following is the primary factor responsible for controlling the rate of blood flow during hemodialysis? A. Dialysate temperature. B. Vascular access type. C. Blood pump speed. D. Ultrafiltration rate. Answer C. Blood pump speed. Explanation. The blood pump speed directly influences the rate of blood flow during hemodialysis. The blood flow rate is essential to ensure adequate dialysis as it determines how much blood passes through the dialyzer per minute. The ideal flow rate is typically between 300 400 ml/min, but this may vary depending on the patient's condition and type of dialysis machine used. Temperature, vascular access type, and ultrafiltration rate do not control blood flow, though they influence other aspects of the dialysis process. The blood pump speed is a critical parameter for ensuring sufficient dialysis treatment while maintaining patient safety. Question 2. Scenario. Mr. Thompson has been undergoing hemodialysis for several years, and today he presents with complaints of muscle cramps during his session. He has been compliant with his prescribed fluid and dietary restrictions. His blood pressure is stable, and his access site appears free of complications. As his dialysis technician, what is the most appropriate initial intervention for managing his muscle cramps? A. Administer a bolus of saline and increase the ultrafiltration rate. B. Slow the blood flow rate and provide gentle massage to the affected muscles. C. Increase the dialysate sodium concentration and monitor for electrolyte imbalances. D. Disconnect the dialysis machine and immediately call for emergency medical assistance. Answer B. Slow the blood flow rate and provide gentle massage to the affected muscles. Explanation. Muscle cramps during hemodialysis are a common complication often caused by rapid fluid and electrolyte shifts, particularly when a significant amount of fluid is being removed. The first line management is to slow the blood flow rate to reduce the rate of ultrafiltration and prevent further rapid shifts in fluid. A gentle massage to the affected muscles may also help relieve the cramp. Optional administering saline and increasing ultrafiltration would exacerbate fluid shifts and could worsen the cramps. Option C, increasing sodium concentration, may not be appropriate without confirmation of electrolyte imbalances. Option D, disconnecting the machine, is unnecessary unless there is a severe complication requiring immediate intervention, which is not indicated in this scenario. Question 3. Which of the following is a key factor to assess when determining the adequacy of hemodialysis for a patient? A. Serum potassium levels alone. B. Pre-dialysis weight and fluid status. C. Dialysis machine model used. D. The patient's history of hypertension only. Answer B. Pre-dialysis weight and fluid status. Explanation. The adequacy of hemodialysis is primarily assessed by evaluating the patient's pre-dialysis weight and fluid status. Pre-dialysis weight is used to determine how much fluid should be removed during the session. Additionally, fluid status i.e. signs of fluid overload or dehydration is essential in determining if the dialysis session has been adequate in removing excess fluid. Serum potassium levels, option A, are important but do not solely determine dialysis adequacy. Dialysis machine model, option C, and the patient's history of hypertension, option D, are also factors in patient care but do not directly assess dialysis adequacy. Continuous monitoring of weight change and fluid status is crucial in tailoring dialysis treatment to achieve optimal outcomes. Question 4. During a routine hemodialysis session, Ms. Roberts reports feeling lightheaded and dizzy. Upon assessment, her blood pressure is 96 mmHg and she is experiencing symptoms of hypotension such as nausea and weakness. The dialysis treatment has been running for 2 hours and the ultrafiltration rate has been set at a high level to remove excess fluid. What is the best course of action to manage Ms. Roberts' hypotension? During this session, A. Increase the blood flow rate and decrease the ultrafiltration rate to improve fluid removal. B. Slow down the ultrafiltration rate, administer normal saline, and monitor blood pressure closely. C. Administer a bolus of potassium and increase the dialysate sodium concentration. D. Disconnect the dialysis machine immediately and prepare to transfer her to the emergency room. Answer B. Slow down the ultrafiltration rate, administer normal saline, and monitor blood pressure closely. Explanation. Hypotension during hemodialysis is a common complication often linked to rapid fluid removal, ultrafiltration. The first step is to slow the ultrafiltration rate to prevent further fluid shifts, which may be exacerbating the hypotension. Administering a saline bolus helps restore intravascular volume, which improves blood pressure. Close monitoring is essential to assess the response to treatment. Increasing the blood flow rate, option A, could worsen hypotension by further lowering intravascular volume. Administering potassium, option C, could be harmful if not specifically indicated by electrolyte imbalances. Disconnecting the machine, option D, is not necessary unless there is a severe complication that cannot be managed during dialysis. Question 5. Which of the following complications is associated with hemodialysis access sites, specifically related to the use of an arteriovenous fistula? A. Infection of the access site. B. Graft thrombosis. C. Dialysis disequilibrium syndrome. D. Steele syndrome. Answer D. Steele syndrome. Explanation. Steele syndrome is a complication associated with arteriovenous fistulas where blood flow to the distal hand or arm is compromised due to the creation of a shunt between the artery and vein. This leads to symptoms such as pain, numbness, and coldness in the affected limb, while infection of the access site, option A, and graft thrombosis, option B, are potential complications of vascular access, not specifically linked to AF creation. Dialysis disequilibrium syndrome, option C, is a neurological condition that can occur during hemodialysis but is not related to AF use. Steele syndrome, option D, specifically arises from blood flow changes caused by an AF, making it the most accurate answer. Question 6. MS. Garcia, a patient on hemodialysis, has been experiencing recurring episodes of muscle cramps during her sessions. She has been instructed to limit her sodium intake, but she has been inadvertently consuming a high-sodium diet. Which of the following dietary changes would most effectively help reduce the frequency of her muscle cramps? A. Increase potassium intake and decrease sodium intake. B. Limit sodium intake and increase fluid intake. C. Decrease sodium intake and increase calcium intake. D. Decrease potassium intake and maintain fluid intake. Answer A. Increase potassium intake and decrease sodium intake. Explanation. Muscle cramps during hemodialysis can be caused by imbalances in electrolytes, especially sodium and potassium. High sodium intake leads to water retention and electrolyte imbalance, contributing to cramps. Reducing sodium intake helps decrease fluid overload and electrolyte shifts. Increasing potassium intake helps prevent hypokalemia, which can also contribute to muscle cramps. Option B. Limiting sodium while increasing fluid intake can worsen fluid overload. Option C. Increasing calcium is not directly related to muscle cramping. Option D would not address the underlying electrolyte imbalance contributing to the cramps. Question 7. What is the most important consideration when selecting the appropriate dialysate composition for a patient undergoing hemodialysis? A. The patient's blood pressure and weight. B. The patient's electrolytes, particularly sodium and potassium levels. C. The type of vascular access used for dialysis. D. The brand of dialysis machine used for treatment. Answer. B. The patient's electrolytes, particularly sodium and potassium levels. Explanation. Dialysate composition is crucial for the effectiveness of hemodialysis as it influences the removal of waste products and the balance of electrolytes in the patient's body. The composition of the dialysate, particularly the concentrations of sodium, potassium, and other electrolytes, is tailored to the patient's individual needs. This adjustment is necessary to prevent electrolyte imbalances such as hyperkalemia or hypokalemia, which can be life-threatening. While blood pressure, weight, and vascular access are important factors in overall dialysis treatment, they do not directly influence dialysate composition. The type of dialysis machine used, option D, does not dictate the composition of the dialysate. Question 8. During a hemodialysis session, Mr. Hayes experiences sudden chest pain, shortness of breath, and a decrease in blood pressure. The dialysis technician notes that the blood leak alarm is activated. What is the most appropriate initial action in response to this emergency? A. Increase the blood flow rate to speed up the treatment and address the chest pain. B. Disconnect the blood lines, check for the source of the blood leak, and notify the healthcare provider. C. Administer a bolus of normal saline and increase the ultrafiltration rate. D. Continue dialysis as usual as the blood leak is likely not significant. Answer. B. Disconnect the blood lines, check for the source of the blood leak, and notify the healthcare provider. Explanation. A blood leak alarm during hemodialysis indicates that blood is escaping from the dialysis circuit, which could be dangerous. The first Priority is to disconnect the blood lines to stop further blood loss and check the dialyzer and tubing for leaks. It is essential to notify the healthcare provider to assess the situation and provide appropriate medical care. Increasing the blood flow rate, option A, could worsen the situation, and administering saline or increasing ultrafiltration, options C and D, would not address the underlying issue of the blood leak. Immediate action is critical to prevent further complications. Question 9. Which of the following is a primary goal of infection control practices in a hemodialysis setting? A. To reduce the cost of treatment for patients. B. To ensure patients experience minimal discomfort during dialysis. C. To prevent the transmission of blood-borne pathogens such as HIV and hepatitis B. D. To increase the efficiency of the dialysis machine. Answer: C. To prevent the transmission of blood-borne pathogens such as HIV and hepatitis B. Explanation: infection control in hemodialysis settings is primarily focused on preventing the transmission of blood-borne pathogens such as HIV, hepatitis B, and hepatitis C. These pathogens can be transmitted through contact with contaminated blood, making strict infection control protocols essential. This includes using sterile technique, proper cleaning and disinfection of equipment, and ensuring that the dialysis staff follows standard precautions. Reducing treatment costs, option A, or minimizing patient discomfort, option B, are not the primary goals of infection control. Increasing machine efficiency, option D, is a secondary consideration and does not directly relate to infection prevention. Question 10. Mr. Johnson has been on hemodialysis for several months and has been experiencing an elevated heart rate, fatigue, and shortness of breath. His lab results indicate a low hemoglobin level. What is the most appropriate intervention to address his anemia during dialysis treatment? A. Increase the frequency of dialysis sessions. B. Administer erythropoiesis-stimulating agents ESA as prescribed. C. Decrease the blood flow rate to reduce workload on the heart. D. Increase the amount of fluid removed during dialysis. Answer: B. Administer erythropoiesis-stimulating agents ESA as prescribed. Explanation: anemia is a common complication in patients undergoing hemodialysis due to decreased erythropoietin production by the kidneys. The most effective treatment is the administration of erythropoiesis-stimulating agents ESA, which stimulate the bone marrow to produce more red blood cells. Increasing dialysis frequency, option A, does not directly anemia. Decreasing blood flow rate, option C, would not resolve anemia and may lead to other complications. Increasing fluid removal, option D, could worsen the patient's symptoms, particularly with low hemoglobin levels, as it may lead to further cardiovascular strain. Proper administration of ESA as prescribed is key to managing dialysis-related anemia. Question 11. A 68-year-old male patient with end-stage renal disease has been on hemodialysis for the past 5 years. His recent lab results show an elevated parathyroid hormone pH level of 350 pgml, normal range 1065 pgml, and a calcium level of 8.8 EL. The dialysis team is concerned about the risk of secondary hyperparathyroidism. What is the appropriate intervention to manage his condition? A. Increase dietary calcium intake to improve calcium balance. B. Administer calcimimetic agents to reduce pH secretion. C. Increase the frequency of dialysis to improve calcium and phosphorus control. D. Initiate phosphate binders to reduce serum phosphorus levels. Answer: B. Administer calcimimetic agents to reduce PTH secretion. Explanation: the elevated pH level in this patient indicates secondary hyperparathyroidism, often caused by altered calcium and phosphorus metabolism in dialysis patients. Calcimimetic agents are the first-line treatment to low pH secretion. Increasing calcium intake, option A, is not effective in managing secondary hyperparathyroidism. In dialysis frequency, option C, may help too. A degree but is not the first intervention. Phosphate binders, option D, are also important but do not directly address the elevated pH. Question 12. A 72-year-old patient with chronic kidney disease, CKD, has been prescribed erythropoiesis-stimulating agents ESAs to treat anemia. She presents to the clinic with complaints of worsening shortness of breath and swelling in her legs. Her recent hemoglobin level is 11.5 grams still, and her iron studies show ferritin of 500 ng/ml, normal range 30400 AgML, transferrin saturation of 45%. What is the most likely cause of her symptoms? A. Anemia is worsening due to poor iron absorption. B. Overcorrection of anemia due to excessive ESA administration. C. Fluid overload due to inadequate dialysis. D. Iron overload from excessive iron supplementation. Answer B. Overcorrection of anemia due to excessive ESA administration. Explanation. Overcorrection of anemia with ESAs can lead to increased red blood cell mass, contributing to increased blood viscosity and cardiovascular symptoms such as shortness of breath and edema. The patient's iron studies suggest adequate iron stores, making iron overload, option D, less likely. Anemia worsening, option A, and fluid overload, option C, are less, given her stable hemoglobin and dialysis status. Question 13. A 60-year-old male patient undergoing dialysis presents with a history of sudden weight gain, leg swelling, and decreased urine output over the past few days. His blood pressure is elevated at 169 mmHg and his serum potassium is 6.2 meckel. The dialysis team is concerned about the risk of hyperkalemia. What is the first-line intervention to manage his elevated potassium? A. Administer sodium bicarbonate to promote potassium shift. B. Increase the dialysis prescription to clear potassium more effectively. C. Start calcium gluconate to stabilize the myocardium. D. Restrict potassium intake in his diet. Answer B. Increase the dialysis prescription to clear potassium more effectively. Explanation. The most appropriate first-line intervention for managing hyperkalemia in dialysis patients is to increase the dialysis prescription to improve potassium clearance. Sodium bicarbonate, option A, and calcium gluconate, option C, are used for acute emergencies but do not directly address the underlying issue. Potassium restriction, option D, part of long-term management but is not sufficient in acute cases of hyperkalemia. Question 14. MS. Martinez, a 55-year-old woman with type 2 diabetes and chronic kidney disease, is scheduled for hemodialysis. She has a history of hypertension and her blood pressure is poorly controlled despite multiple antihypertensive medications. The dialysis team is concerned about her risk for hypertension during dialysis. What is the most appropriate intervention to manage her blood pressure during dialysis? A. Increase the ultrafiltration rate to remove excess fluid and reduce blood pressure. B. Administer antihypertensive medications before dialysis to control blood pressure. C. Reduce the dialysate sodium concentration to help manage blood pressure. D. Slow the blood flow rate during dialysis to prevent rapid fluid shifts. Answer A. Increase the ultrafiltration rate to remove excess fluid and reduce blood pressure. Explanation. In patients with hypertension and fluid overload, increasing the ultrafiltration rate during dialysis can help reduce blood pressure by removing excess fluid. Administering antihypertensive medications, option B, may be necessary but is not always effective in dialysis patients. Adjusting sodium concentration, option C, can help. Increasing ultrafiltration is the primary method to manage blood pressure during dialysis. Slowing the blood flow rate, option D, is not effective for blood pressure control in this scenario. Question 15. A 60-year-old male patient with chronic kidney disease and coronary artery disease has been receiving hemodialysis for the past year. He presents with increasing fatigue and chest pain during dialysis. His recent lab results show a decrease in hemoglobin to 9 grams still. The dialysis team suspects that the patient is experiencing anemia. What is the most appropriate initial intervention? A. Administer erythropoiesis-stimulating agents, ESA, and iron supplementation. B. Increase the blood flow rate during dialysis to improve oxygen delivery. C. Start intravenous iron therapy and monitor iron studies closely. D. Recommend dietary modifications to increase iron intake. Answer A. Administer erythropoiesis-stimulating agents, ESA, and iron supplementation. Explanation. Anemia in dialysis patients is often managed with erythropoiesis-stimulating agents, ESA, to promote red blood cell production, along with iron supplementation to support hemoglobin synthesis. Increasing the blood flow rate, option B, is not appropriate for managing anemia. Intravenous iron therapy, option C, can be beneficial but should be combined with ESA administration for optimal results. Dietary modifications, option D, are less effective compared to ESA and iron therapy in this case. Question 16. Mr. Williams, a 65-year-old male with a history of diabetes and chronic kidney disease, presents to the clinic with signs of malnutrition, including weight loss, muscle wasting, and fatigue. His serum albumin is 2.2 grams still, and his transferrin level is low. The dialysis team suspects that he may be suffering from protein energy wasting, PEW. What is the most appropriate intervention to address his malnutrition? A. Increase the frequency of dialysis to enhance nutrient removal. B. Administer parenteral nutrition to improve nutritional intake. C. Encourage oral supplementation with high-protein drinks and adjust diet. D. Start an erythropoiesis-stimulating agent, ESA, to improve appetite. Answer: C. Encourage oral supplementation with high-protein drinks and adjust diet. Explanation: in patients with protein energy wasting (PEW), the most effective approach is to improve nutritional intake, particularly with high-protein supplementation. Increasing dialysis frequency (option A) will not address the root cause of malnutrition. Parenteral nutrition (option B) may be necessary in severe cases but is not the first-line intervention. ESA therapy (option D) can help with anemia but does not directly improve nutritional status. Question 17. A 45-year-old patient with end-stage renal disease is undergoing hemodialysis. During his dialysis session, the nurse notes that his vascular access site is becoming increasingly swollen and red, and the patient complains of pain. The dialysis team is concerned that he may have a vascular access infection. What is the most appropriate intervention? A. Increase the blood flow rate to optimize dialysis and prevent infection. B. Administer antibiotics and assess for signs of sepsis. C. Initiate thrombolytic therapy to clear any clot present in the access site. D. Temporarily stop dialysis and refer the patient to the vascular surgeon for access site evaluation. Answer: B. Administer antibiotics and assess for signs of sepsis. Explanation: the most likely cause of the patient's symptoms is a vascular access infection. The first step is to administer antibiotics and assess for signs of sepsis, which can be life-threatening. Increasing the blood flow rate, option A, will not resolve the infection. Thrombolytic therapy, option C, is used for clot management but is not indicated here. Stopping dialysis. Referring to the vascular surgeon, option D, may be necessary if the infection is confirmed, but immediate antibiotic treatment is crucial. Question 18. MS. Ford, a 70-year-old female patient with chronic kidney disease, has been prescribed phosphate binders to manage hyperphosphatemia. She has been taking the prescribed medication consistently, but her phosphorus levels remain elevated. The dialysis team is concerned about the effectiveness of her treatment. What is the most appropriate next step? A. Increase the dose of phosphate binders to better control phosphorus levels. B. Add a second class of phosphate binders to her treatment regimen. C. Adjust the dialysis prescription to improve phosphorus clearance. D. Recommend dietary modifications to reduce phosphate intake. Answer: C. Adjust the dialysis prescription to improve phosphorus clearance. Explanation: while phosphate binders options A and B are important in managing hyperphosphatemia, adjusting the dialysis prescription to improve phosphorus clearance is the most effective next step. This may involve increasing the frequency or duration of dialysis. Dietary modifications, option D, are helpful but should be part of a comprehensive approach. Think optimizing dialysis and phosphate binder use. Question 19. A 59-year-old male patient with chronic kidney disease and diabetes presents to the clinic with complaint of pain and redness at his dialysis access site. The access site is swollen and the patient has a fever of 101 degf. What is the most appropriate intervention for this patient? A. Increase the blood flow rate to improve dialysis efficiency. B. Initiate Romaine antibiotics and assess for systemic infection. C. Perform an urgent dialysis session to clear any infection from the bloodstream. D. Refer the patient to the vascular surgeon for emergency surgical intervention. Answer: B. Initiate Romaine antibiotics and assess for systemic infection. Explanation: this patient likely has an infection at the dialysis access site, which requires immediate initiation of Romaine antibiotics and monitoring for systemic infection. Increasing the blood flow rate, option A, and performing dialysis, option C, will not address the infection directly. Surgical intervention, option D, may be necessary if the infection is severe, but priority is antibiotic therapy. Question 20. Mr. Jackson, a 55-year-old patient with chronic kidney disease, is receiving hemodialysis. His recent lab results show a calcium level of 8.5 mdl, a phosphorus level of 6.0 EDDL, and a level of 300 pgml. The dialysis team is concerned about managing his mineral and bone disorder. What is the most appropriate intervention? A. Initiate a calcium-based phosphate binder to reduce phosphorus levels. B. Increase the calcium concentration in the dialysate to improve calcium balance. C. Administer calcimimetic agents to reduce parathyroid hormone secretion. D. Recommend dietary restrictions on calcium and phosphorus intake. Answer: C. Administer calcimimetic agents to reduce parathyroid hormone secretion. Explanation: the elevated pH level in this patient suggests secondary hyperparathyroidism due to disturbed calcium and phosphorus metabolism. The most effective treatment is the use of calcimimetic agents to reduce pH secretion. Calcium-based phosphate binders, option A, may be helpful but are not the first-line treatment for elevated pH. Increasing calcium concentration, option B, can be harmful in this case as the calcium level is already in the lower range. Dietary restrictions, option D, can help manage phosphorus, but they are not sufficient for addressing secondary hyperparathyroidism and elevated PTH levels directly. Question 21. A 45-year-old female patient on hemodialysis presents with a newly formed nav fistula in her forearm. During her dialysis session, she reports swelling and tenderness at the site of the fistula. Upon assessment, you also notice a bruit but no signs of infection. What is the most likely cause of the swelling and tenderness? A. Stenosis of the AV fistula. B. AV fistula thrombosis. C. Excessive arterial pressure from the fistula. D. Post-surgical inflammation and edema. Answer: D. Post-surgical inflammation and edema. Explanation: post-surgical inflammation and edema, option D, are common immediately following the creation of an AV fistula, especially within the first few weeks. This swelling is typically due to the body's healing response and should improve with time. A bruit, option C, is often heard in the early stages of AV fistula development, indicating proper blood flow through the fistula. Stenosis, option A, thrombosis, option B, could cause more severe complications but are typically associated with chronic issues or a lack of blood flow, not the early post-surgical period. Question 22. During a hemodialysis session, a 50-year-old male patient experiences muscle cramps. He has a history of chronic kidney disease and is on a regular dialysis schedule. Which of the following interventions is most appropriate for managing his muscle cramps? A. Increase the ultrafiltration rate. B. Administer a saline bolus. C. Encourage the patient to stretch the affected muscle. D. Reduce the dialysis time by 30 minutes. Answer: C. Encourage the patient to stretch the affected muscle. Explanation: muscle cramps during dialysis are often related to rapid fluid shifts or low sodium levels. The most appropriate intervention is to encourage the patient to stretch the affected muscle, option C, which can relieve the cramping. Increasing the ultrafiltration rate, option A, could worsen the cramping by further dehydrating the patient. Administering a saline bolus, option B, is helpful in addressing dehydration or low blood pressure, but is not the first-line treatment for cramps. Reducing dialysis time, option D, is not a recommended intervention as it does not address the root cause of the cramps. Question 23. A dialysis technician notices that a patient's blood pressure begins to drop during the middle of a hemodialysis session. The patient reports feeling dizzy and lightheaded. Which of the following is the first step the technician should take to address the hypotension? A. Administer intravenous fluids to raise blood pressure. B. Lower the dialysis blood flow rate. C. Increase the dialysate temperature. D. Reposition the patient to a more upright position. Answer: B. Lower the dialysis blood flow rate. Explanation: the most appropriate first step in addressing dialysis-induced hypotension is to lower the dialysis blood flow rate. Option B. This helps to reduce the rate of fluid removal and mitigate hypotension. Administering intravenous fluids, option A, may be helpful, but the immediate priority should be stabilizing the patient's blood pressure through adjustments to the dialysis procedure. Increasing the dialysate temperature, option C, is not a recommended response and could exacerbate the hypotension. Repositioning the patient, option D, may help but is not the first-line intervention for hypotension during dialysis. Question 24. A patient on hemodialysis presents with signs of embolism, including chest pain, difficulty breathing, and low oxygen saturation levels. What is the most appropriate action for the dialysis technician to take? A. Turn off the dialysis machine and immediately begin CPR. B. Clamp the venous bloodline and position the patient in the Trendelenburg position. C. Increase the dialysate flow rate to flush out any air in the system. D. Administer supplemental oxygen and monitor vitals until the nephrologist arrives. Answer: B. Clamp the venous bloodline and position the patient in the Trendelenburg position. Explanation: In the case of an air embolism, the technician should immediately clamp the venous blood line to prevent any further air from entering the circulatory system and position the patient in the Trendelenburg position, option B, to help prevent the air from traveling to the lungs or brain. Administering CPR, option A, is premature unless the patient is unresponsive or shows signs of cardiac arrest. Increasing the dialysate flow rate, option C, would not address the underlying issue and could worsen the situation. Administering oxygen, option D, is important, but immediate action to prevent further air entry into the bloodstream is crucial. Question 25. During a routine hemodialysis session, a technician notices that the dialysis machine alarms are triggered for a high-pressure issue. After checking the system, the technician finds no visible clots or blockages. What is the most likely cause of the high-pressure alarm? A malfunctioning blood pump. B, an incorrect dialysate flow rate. C, an air bubble in the blood line. D, an issue with the dialyzer filter. Answer: D, an issue with the dialyzer filter. Explanation: a high-pressure alarm typically indicates an issue with the dialyzer filter. Option D. This can be caused by a blockage or fouling of the filter, which restricts blood flow through the dialyzer. A malfunctioning blood pump, option A, could also cause pressure issues, but is less likely if the pump is functioning properly. An incorrect dialysate flow rate, option B, generally causes issues like an filtration, but not typically high-pressure alarms. An air bubble, option C, would usually cause other types of alarms, such as air detection or blood leak alarms, rather than high-pressure alarms. Question 26. A 70-year-old patient undergoing hemodialysis has a history of hypertension and diabetes. His recent lab results show a potassium level of 6.2 microl, which is above the normal range. What should the dialysis technician immediately assess during this session? A. Decrease the dialysate sodium concentration. B. Increase the blood flow rate to promote faster dialysis. C. Monitor the patient's electrocardiogram for signs of arrhythmias. D. Administer a potassium binder to reduce levels. Answer: C. Monitor the patient's electrocardiogram for signs of arrhythmias. Explanation: hyperkalemia, high potassium levels, is a serious electrolyte imbalance that can lead to dangerous cardiac arrhythmias. The dialysis technician should immediately monitor the patient's echo, option C, for signs of arrhythmias which can occur when potassium levels are elevated. Decreasing the dialysate sodium concentration, option A, is not an intervention for hyperkalemia. Increasing the blood flow rate, option B, might enhance dialysis efficiency but does not directly address the immediate risk of arrhythmias. Administering a potassium binder, option D, could be an option but should be done under the direction of a physician. Question 27. A patient on hemodialysis asks the technician about the long-term effects of dialysis. Which of the following is the most accurate statement the technician can provide? A. Dialysis will cure the patient's kidney disease and prevent further complications. B. Dialysis is a temporary measure that only improves kidney function for a short period. C. Dialysis helps manage kidney disease but does not reverse it or cure it. D. Dialysis has no impact on the patient's overall health status and is just a mechanical process. Answer: C. Dialysis helps manage kidney disease but does not reverse it or cure it. Explanation: hemodialysis helps manage the symptoms of kidney failure and maintain homeostasis, but does not reverse or cure the underlying kidney disease. Option C. The technician should educate the patient on the importance of ongoing dialysis treatments in managing fluid balance, electrolytes, and waste products, but it is not a cure. Dialysis is supportive treatment, not a cure. Option A. It is not just a temporary measure or a process that has no impact on overall health. Options B and D. Question 28. During a routine dialysis session, a technician notices a rapid increase in the patient's weight over the past 24 hours. The patient has been feeling fatigued and has swelling in their legs. What is the most likely cause of these symptoms? A. Fluid overload due to inadequate ultrafiltration during the previous dialysis session. B. Malnutrition causing protein loss. C. Sudden decrease in sodium intake. D. An infection related to vascular access. Answer: A. Fluid overload due to inadequate ultrafiltration during the previous dialysis session. Explanation: fluid overload, option A, is the most likely cause of the patient's symptoms, including weight gain, fatigue, and swelling. Inadequate ultrafiltration during the previous dialysis session could have led to the retention of excess fluid, which accumulates in the body. Malnutrition, option B, may cause weakness or muscle wasting, but it is to cause the symptoms described. Decrease in sodium intake, option C, could lead to electrolyte imbalances, but is not the primary cause of fluid retention. An infection, option D, could cause symptoms like fever and redness at the access site, but not necessarily the general symptoms of fluid overload. Question 29. A 55-year-old patient is undergoing hemodialysis and presents with signs of dialysis disequilibrium syndrome, DDS. Which of the following is the most appropriate intervention to manage this condition? A. Increase the blood flow rate to speed up dialysis. B. Administer bicarbonate to correct acidosis. C. Slow down the dialysis treatment and provide supportive care. D. Increase the ultrafiltration rate to remove excess fluid. Answer: C. Slow down the dialysis treatment and provide supportive care. Explanation: dialysis disequilibrium syndrome, DDS, a complication of dialysis that can occur when there is a rapid removal of waste products from the blood, leading to neurological symptoms. The most appropriate intervention is to slow down the dialysis treatment, option C, and provide supportive care, which may include administering fluids and monitoring signs. Increasing the blood flow rate, option A, or ultrafiltration rate, option D, could worsen DDS by further accelerating fluid and waste removal. Bicarbonate administration, option B, is not typically used for managing DDS but may be used to address acidosis in other situations. Question 30. A patient with an AV fistula presents with redness, warmth, and swelling around the access site. The patient reports mild pain, but there is no fever. What is the most appropriate course of action? A. Perform immediate cannulation to ensure dialysis treatment continues. B. Apply warm compressors and observe the access site for any changes. C. Increase the blood flow rate to reduce the risk of clotting. D. Report the findings to the nephrologist for possible infection. Answer: B. Apply warm compressors and observe the access site for any changes. Explanation: redness, warmth, and swelling around an AV fistula could indicate inflammation or early signs of infection, but the absence of fever suggests it may not be an active infection yet. The first step is to apply warm compressors, option B, and observe the site for any changes. Immediate cannulation, option A, should be avoided until the site is evaluated. Potential complications: increasing the blood flow rate, option C, would not help with local access site issues. Reporting the findings, option D, is important if the condition persists, but it is not the immediate first step unless symptoms worsen.